I'm going to be talking about the final stages of polio eradication. To do that, there's first a few things that we need to cover so that we can have a better understanding of polio eradication and where we are currently. So the first thing is that when we talk about eradication of poliomyelitis, we're actually talking about eradicating 3 infectious diseases. So they are all viruses and they're all poliovirus, but there's actually 3 serotypes, serotype 1, 2 and 3. And there's very little cross-immunity between them, both in terms of naturally acquired immunity, but also vaccine-associated immunity. And consequently, that means when it comes to carrying out control activities, you actually need to control against 3 different pathogens all at the same time. The virulence between the different serotypes also varies. So the most virulent of the serotypes is serotype 1, followed by 3, followed by 2. And in terms of where we are, and the original plan was to eradicate poliomyelitis by the year 2000. We have actually done incredibly well, because the last case of wild type 2 was seen in 1999, so we eliminated that one. And the last case of wild type 3 was seen in 2011, I believe in Nigeria. We've also been able to eliminate polio from India, and I think that was a real sticking point for quite a lot of time. The main way that we go about controlling poliomyelitis is through vaccination. So I'm just going to focus on the one of the vaccines developed in the 1960s, so developed by Albert Sabin. And so this vaccine is an oral polio vaccine where you're actually infecting someone with a live virus, but it's been attenuated. So it's been passaged through animals to ensure that you cause infection and you produce an immune response to that infection, which is very strong. But there's a very, very, very low risk of causing disease through vaccination. So that's why it works very well as a vaccine. And this vaccine is largely used in low and middle income countries, so the countries particularly in Africa, Southeast Asia, and also in South America. And the oral polio vaccine, it's a blessing, but it's also a curse. So it's a blessing because it protects against both infection and paralysis. And protecting against an infection is particularly important if you actually want to eradicate an infectious disease, because essentially you want to limit all infection rather than just the disease, the manifestation of the infection. It's extremely cheap, so each dose of the oral polio vaccine is about 20 cents, and so this is incredibly good if you're going to be immunising several million children on an annual basis. It has to be a cheap vaccine. It's also very easy to administer, just a couple of drops in the mouth. And this is very different, and it means that you can carry out mass immunisation campaigns using volunteer vaccinators. And for this reason, the mobilisation of support for controlling this infectious disease is actually things can happen very rapidly. You can take the vaccine to the people rather than assuming that the people will come to the healthcare centre. But it's also a curse. So it's a curse because because it's a live virus, it can mutate. And the ability of the polio virus to mutate happens with a certain molecular clock. And if the mutation is able to happen in an area with relatively low population immunity, it can also result in circulation of this vaccine virus strain. And with enough mutation occurring when it's transmitting from one individual to the next, it can then revert to causing disease, and so this is what we call vaccine-derived poliomyelitis. One of the great things about working on poliomyelitis eradication is the surveillance network. So there's an enormous surveillance network that is quite, I think, unique to poliomyelitis eradication. And so what happens is that you're looking for the manifestation of disease, and so that is cases of acute flaccid paralysis. And so these cases of acute flaccid paralysis, it's a syndrome. It's not just caused by poliovirus infection. It's caused by lots of infectious and non-infectious things. And a majority of cases of acute flaccid paralysis aren't caused by polio. But each case is investigated equally. So, for example, to distinguish between a case of poliomyelitis and non-polio AFP, stool samples are taken, and each of these stool samples are sequenced. The sequences are used to better understand the relationship, to also first diagnose whether an individual has poliomyelitis, but then to also understand the relationship of that case to other cases, which is very, very important. So this huge global surveillance network consists of about 100,000 cases annually, with about 60,000 in Southeast Asia, so largely India, Pakistan and Afghanistan, and also about 20,000 cases in Africa. One of the reasons why the surveillance has to be quite strong, and you have to be able to, if there are cases of acute flaccid paralysis, you want them reported, is because the high asymptomatic ratio for poliomyelitis. So for every case, there's generally about 200 or so infections. So you're only ever looking at the tip of the iceberg. So of course, consequently, you want to have a really good idea about, where that iceberg is. And one final thing as well is that this is a virus, so it's mostly fecal oral transmission. There aren't any known vectors, and it just infects people, just for those of you who work majority on malaria. So this is where we are currently. So this slide illustrates one of the weekly summary reports that people interested in polio eradication receive. And so the first thing that you should notice is that there are red dots and there are green dots. So all of the red dots in the last 6 months are cases of wild-type poliomyelitis, and these are all geographically isolated to Afghanistan and Pakistan. So I'll talk about those a little bit more in the second half of my talk. The other thing to notice is the absence of the red dots in the whole of Africa. So for 7 months now, there have been no cases of wild-type poliomyelitis in Africa, and this is an amazing achievement. The only blight in this reporting is the green dots here. So this refers to the circulating vaccine-derived poliovirus cases in the northern areas of Nigeria, just on the border of South Sudan, and there's actually a type 1 in Madagascar at the moment. But the important thing to emphasise is that even the last case of vaccine-derived poliovirus in Nigeria was back in November of last year. So that's what I'm going to be talking about for the first half. So, Nigeria. Nigeria has historically been the main heart of poliovirus transmission in Africa, and it has resulted in a number of outbreaks in countries in other areas of Africa and beyond. And you can see in this time series analysis there have been several series of annual epidemics in Nigeria, both from type 1, so that's the red bars, type 3, and then also these vaccine-derived poliovirus. But what I'm actually going to focus on is the right-hand side of the figure, which is the number of cases that have dwindled since 2010 in Nigeria, to the extent that in 2014 there were just 6 cases of wild-type poliomyelitis. So what changed in Nigeria in 2010? Something definitely changed. And actually it wasn't something, it was pretty much everything. So the first thing, one of the first things that happened was the World Health Assembly declared poliomyelitis eradication a programmatic emergency for public health, and this led to a lot of national and international discussions that were happening previously, but I think the surge in responses and actual actions in the ground really changed. And there was a huge surge in increased political commitment from community leaders down at the ward level all the way through to government. There was an emergency action plan in 2011 and an emergency operations committee developed in Abuja, but also focused in northern Nigeria. And there was enforced accountability at all levels, so using sanctions and rewards, for example. And it wasn't just stuff happening on paper, it was happening for real on the ground. In terms of better tools, there was the introduction of the bivalent oral polio vaccine in Nigeria. So up until this point, Nigeria would use the trivalent vaccine, so that would protect against all 3 serotypes, but at a cost of lowered vaccine efficacy. The introduction of the bivalent meant that you could protect against both type 1 and type 3 poliomyelitis. The other thing that happened was improvements in vaccination coverage. And what I'm going to focus on today is the use of micro-planning for vaccinations using GIS tools. So it's worth mentioning that this isn't my work, it's work of other people, but I'm so impressed by it, I wanted to talk about it. So micro-planning for vaccination campaigns can be incredibly tricky. You know, it's a huge mobilisation of people. It costs millions of dollars for each vaccination campaign if it's a national campaign. And it was quite clear for quite some time that children in accessible areas were being persistently missed during campaigns, so during these house-to-house visits. So there was a need to improve training, planning, supervision and accountability. Producing accurate maps were really quite important as well, and that's what I'll touch on later. And post-campaign monitoring data was relatively limited. So what would typically happen is that you would have a group of volunteer vaccinators going house to house, putting little drops into children's mouths, and they would mark the finger of children that they'd vaccinated. Several days later, this post-campaign monitoring would happen, where there'd be an independent team, unfortunately using the same microplans, visiting house to house and seeing how many children they spotted with finger marks. And so from that, you can assess relatively quickly how successful the immunisation campaign was. But it wasn't working that well. So digital methods were used to collect settlement data, healthcare and admin boundary data, to integrate GIS maps into microplanning, to use GPS trackers to follow vaccination teams, and to implement a web-based vaccination tracking system. So some of this work, well, most of the work was summarised in the paper in the Journal of Infectious Disease. There's a big polio special edition there, but also some of the work was summarised in the International Health Special Edition Journal as well. So this figure here just illustrates like a typical microplan used in, well, most parts of Nigeria, but also from my own experience in Pakistan and Afghanistan. And so here you've got 5 different areas. There's a road, you know, it's hand drawn. There are some details of some of the settlements. They all look about the same. It's not particularly clear how you get from one to the next. One of the things that was done was to have teams go around in particular parts of northern Nigeria to map the location of settlements, their names, if they indeed had some names, healthcare facilities, and also larger sort of more semi-urban areas. And so these 5 areas here seem sort of relatively circular. When they're actually physically drawn out on a GIS map, you can see that there's some sort of inefficiencies in how you decide where the teams are. And what we're going to do is that we're going to go to, well, this is a publicly available website, you've got the address up there. I'm just going to run a video about the vaccination tracking system for that area, Buju, in, I think it was in Jigawa State, wasn't it? So I didn't want to do this live because I was petrified that it would go horribly wrong, so I can just press play and we can watch it. So the first thing that we want to do is that we want to type in here the location. So we're typing in Buju and we can see that it comes up as one of the options. And then we load up the data, all the other information for the settlement. We can also look at the microplans here. They're not quite relevant for us right now, but here you can see the improvement in vaccination coverage in the most recent campaign. What we can now do, and this information was available to vaccination planners at the time, and you know, it all happens in real time, is that each team of people were given GPS trackers, typically mobile phones, and the GPS tracker would just record in some period of time where they were. And what they need to do is that they just need to visit every house in this settlement of Buju. And so you can see the colours changing in some of these dots, and this is when the vaccinators are recorded as being there. So we'll see a light blue, set of light blue dots coming up. So you know, there's zigzagging across the streets here. These guys here, they just went straight down the street. And so you can follow this in real time. And the advantage is that the immunisation planners can view where vaccination teams have been, but also importantly where they haven't been. So for example, these red squares here suggest that there's no evidence that the immunisation teams visited those houses. And the advantage is because the information is there right then, the next day you can go back and revisit those houses. So it really was quite a powerful tool. I mean, it looks quite nice, and I can do a nice presentation about it, but actually in the field it was also incredibly useful. Now, one of the reasons why we've got a pretty good idea about this is the improvements in vaccination coverage. So I talked a little bit about the post-campaign monitoring, so looking at the finger marking surveys, and in the high-risk districts, which were sort of recorded as to whether there were cases of poliomyelitis recently, you see an increase in vaccination coverage as indicated by the dark green bars. And so at the end of, I think it was September 2014, you had this improvement in immunisation coverage, so about 80% of households being reached. We also can see from the GIS mapping, basically all the squares are starting to go green instead of being red. And work that I've been doing in collaboration with WHO, but actually focusing a lot more in Pakistan, is looking at new methods to estimate vaccination coverage. So rather than using this data that's immediately available, we can look back sort of slightly further in time from the AFP surveillance data. So this data includes information about vaccination histories for children which have acute flaccid paralysis but don't have polio. And we can compare this to the vaccination calendars, which are spatially explicit, and compare the reported number of doses to what they should have received. And in Jigawa State, where this particular example was from, we had an estimate for vaccination coverage, so the probability that a child is going to be reached during a campaign of about 30% prior to 2010. This value then improved up to 50% in 2011. And I mean, the advantage of this sort of work is that we can also look at under-vaccinated populations and that sort of thing, that I won't talk too much about actually. So Nigeria is extremely close to elimination. We're nearly there, so just 6 cases in 2014. It's a fantastic achievement, and it's been achieved in the background of having excellent surveillance for cases, across the board improvements in vaccination campaign coverage, and also stuff in this example that I haven't talked about, environmental surveillance hasn't picked up any cases of wild-type poliovirus. So with the environmental surveillance, there are particular sites where sewage is sampled and to see whether there are any traces of poliovirus in the sewage. There's been a huge commitment to polio eradication in Nigeria, and it's really exciting to see. And I think in this sort of climate, the resources have enabled digital methods to be used successfully. However, it's not yet time to celebrate. One of the reasons for this is in the environmental surveillance, there's evidence of circulating vaccine-derived poliovirus in the northern states. So in 2015, there's been a couple of positive samples, but this is in the absence of any cases of poliomyelitis caused by this particular virus type. But there's evidence of circulation. The other thing to worry about a little bit as well is the relatively low levels of population immunity. So this is just from routine immunisation coverage, but this is where most immunity against vaccine-derived type 2 poliovirus comes from. And you can see in the northern states there's quite low levels of population immunity from, so this is data from the analysis of data from the DHS surveys. And then when we multiply that up by the sort of data that Andy Tatton makes available on the numbers of children in northern Nigeria, you can see that there's a peak in the numbers of unvaccinated in the sort of central northern zone of Nigeria. So, moving on to Pakistan. In Pakistan, it's a different situation. There is extensive transmission of poliovirus across the country. This figure shows a map of Pakistan and some of the provinces and some of the key areas. So in red, that's where there's been a relatively high incidence. So this map was from 2010 to 2011, but to be honest, the map hasn't changed since that time. We've got here just a time series of the incidence of cases on a monthly basis. And in 2014, certainly on this map, there was 184 cases up to about September. By the end of the year, there was over 300. There is a huge amount of commitment to eradicate polio in Pakistan, but this is within a climate of fear and instability. So since 2012, there's been numerous polio workers killed when they visit house to house. This has been regarded as something quite negative by certain parts of society, so sort of anti-governmental elements such as the Taliban. And there's been several murders, and it's very distressing. There's also been a ban on vaccination, so most notably in northern Waziristan, which is sort of in this area part of the federally administered tribal areas. In places where there's in places where there is accessibility, there's also poor management of immunisation campaigns, but also of surveillance activities. And I think in this environment, the GPS monitoring that we've just seen in Nigeria is going to be risky. Currently, there's no plans to implement that. Recently, the WHO International Health Regulations has recommended vaccination at exit points, or at least certification, and so this was most recently made just in February. There's been several emergency eradication plans. There is a Prime Minister's polio monitoring cell, and recently an emergency operations committee centre, even in a similar format to what was achieved in Nigeria, has been set up, but unfortunately it was delayed. So there are glimmers of hope, but it's not the resounding success that we've already seen in Nigeria. So this is another video that I want to show you about some of the work that the Global Polio Eradication Initiative have been doing to introduce modern digital methods. So one of the things about the Polio Eradication Initiative and the surveillance and the vaccination activities is that there's huge amounts of data, and dealing with that data is actually quite difficult. So we're just going to describe 3 of the different systems. They're all integrated into each other, but just for clarity, there's 3 different sorts. So the first is each country needs to upload files about cases of acute flaccid paralysis, whether they're caused by polio or not, because it tells us information about population immunity. Of course, all of this information needs to be checked, the errors need to be reported, and they need to be resolved. All of this information is spatially aggregated as well, so you need to be able to link the correct district to the correct case. Spelling errors can creep in quite easily, for example. One of the other things that is very important for some of the program managers is monitoring of SIA campaigns, so these mass immunisation campaigns, because each of these campaigns, they're extremely expensive. It's a huge mobilisation of people, of resources, and it's also about getting the vaccine into the right place as well. So a lot of these campaigns are planned about 6 months in advance, but of course partners such as UNICEF need to know that there's a certain number of doses that are going to be allocated to that country at that period of time. So this is just a snapshot of the sort of information that is readily available, that prior to this sort of database would be a series of Excel spreadsheets that could go horribly wrong. What we have here is the POL-IS dashboard. So this is an incredibly informative resource where you have the location of current cases. I think it goes back to the last 6 months that are displayed at least. In the middle figure, you have the number of vaccination campaigns since the last case experienced in that place. And then on the far right, you have information about the surveillance quality. So, for example, how many cases of this non-polio AFP do you see? How good are the stool samples? So, can you actually extract virus from these stool samples, for example? And then all the information below is just like additional information that is available. And you can query it, you can download it, and for me the important thing is knowing the location of the cases, the date of onset, the vaccination history of those children, and also in terms of vaccination, how good a quality these campaigns are meant to be. So what we're doing now is that we're just focusing in on Pakistan and Afghanistan, and you can see these red dots again, but there's actually also some red squares. So these are the samples of sewage samples, so the environmental sampling that I'll talk about in a second. Some of the other things that we can do is that we can zoom in. So I think we're searching immunisation activities in Pakistan, just to see what vaccine is going to be used, when it's going to be used, and which age group we're going to target. So most of the time immunisation campaigns target children aged from 0 to 5, but sometimes it's thought we need to target additional age groups. We can also have a look at, we can also compare like the location of cases and also how good surveillance activities are happening, so we can compare and contrast. And so, for example, one of the questions is, well, in a place where we see cases, is the surveillance compromised in some way? Are we seeing all of the cases of poliomyelitis here, or do we need to look harder? One of the other things that we can look at is the immunisation campaigns happening in countries bordering the area. So, for example, in Pakistan and Afghanistan, there is a onward risk of poliomyelitis spread into Iran and Iraq, and that did actually happen in Iraq in 2014. And so it's quite important to have a look, not just inside your own borders, but across the border, what the immunisation campaigns are there. And then the final bit is just looking at an example report. So currently, most of the cases are reported in Pakistan. A really simple thing to do is just like querying, well, how many campaigns are there going to be in the next 6 months? What is the quality of those campaigns expected to be? And previously, that was actually quite a difficult thing to do, and it would be quite time-consuming. And this example just gives you a couple of clicks of buttons, and then you have the information readily available. So this is put together by Paul Chenoweth at WHO, and the background of the work is also done by Novelty, which are the same company that does the immunisation coverage work in Nigeria. So the final bit of work that I'm going to talk about is taking advantage of the data that are available to better understand what's really happening. So since 2010, there's been these environmental samples in Pakistan, and these capture virus shedding in the wider community, and we're talking about infection rather than disease here. It's thought to be more sensitive to poliovirus circulation than acute flaccid paralysis, but we don't really have a handle on what the field sensitivity is going to be. We know how good the environmental sampling is if you definitely have poliovirus in your sewage sample, but actually if you're just taking a bucket from a river in some part of Pakistan, we don't really know how effective that is in detecting poliovirus infection. So by combining the data sets together, we're able to ask exactly those questions. So what I've been doing recently with the folks in WHO Pakistan is combining the data sets together. So we have the case reports present in the POLIS system that I've just described, so the age of onset, the location at which children are affected with poliomyelitis, and we can compare this to the environmental samples. So we've just got a map here of the 11 districts where there are environmental sampling in Pakistan. Each district typically has sort of 3 or 4 different sites that are routinely collected, so that allows us to have consistent information that we can look at over time. One of the things that I get quite excited about is informative mathematical modelling. And so here what I have is a multi-state model, or it's called sometimes called a latent class analysis model. So each district over time is either going to be uninfected or infected. And this latent process is something that we don't directly observe, but we want to estimate from the data that we have. So we have information from surveillance for poliomyelitis. So if we see a case, we know that that district is infected. It's just that if we don't see any cases, we don't know whether we're just not seeing it or whether the district is truly uninfected. We also have these environmental surveillance sites. So typically 4 samples are collected per month, and so we have a probability of being positive, and from that we can estimate the sensitivity of both of these data sources, these 2 parameters here, using an integrated Bayesian framework. So the observations that we have for the 11 districts in Pakistan show quite a lot of variation both in space and time. So the dark red squares indicate that all 4 samples were positive for poliovirus at that time. So for example in Peshawar, which does report quite a lot of cases, funnily enough, you basically have persistent evidence of infection. The only exception is this observation here in the middle, where none of the sewage samples were positive, but actually this black dot indicates that there was a case of poliomyelitis. So clearly there's some ambiguity in the data, but a lot of this is related to differences in surveillance quality. We can also notice that these three areas, Karachi, so the megacity in Pakistan, they're largely associated with each other, at least the rate at which things are positive are associated, and we also have a cluster of cases in the latter half. When we just look at the raw data for environmental sampling, the average duration of infection is about 4 months. When we combine the data together in this Bayesian framework, we get out information about the field sensitivity for acute flaccid paralysis surveillance. So within a district, there's a 17% chance of detecting cases of poliomyelitis if a district is infected. And considering that asymptomatic ratio of 1 in 200, that's actually pretty good, but it does also suggest that there's extensive transmission in a district. With environmental samples, just one sample gives you a sensitivity of 65%. And of course, because you're collecting 4 samples in a month, your sensitivity is actually quite high. When you combine both together, it's largely driven by environmental sampling, but AFP does definitely play a role in understanding the extent of poliovirus circulation. In addition to this, the infection rates, so transitioning from uninfected to infected, there was a 0.2 chance every month, and then the duration at which districts were infected for was about 8 months. So what does this tell us going forward? You know, what we really want to know is when we're really when we're nailing immunisation campaigns in Pakistan and we don't see any cases and our environmental samples are negative, what does that actually mean? And so here we're interested in the false emission rate. So essentially, if you have a set of negative samples, how sure are you that this district is uninfected? And with just, if you look at the purple lines, that's just the information from surveillance for acute flaccid paralysis. And so you can see that essentially most of the time, if you have negative AFP, the chances are that the district's actually infected. But the advantage of the environmental sampling is that this false emission rate starts to reduce. And so if you actually have 4 negative samples in quite a few of these districts, it results in quite a lot of certainty that that district is no longer infected. The main reason why each of these bars change is that each district has a different prevalence of infection. And so it's this prevalence of infection that's really important to understand, taking this model further. One of the other things that we want to do is combine this data with some of the GIS water capture information for the specific sites, and that will be work that we're going to do in the future. So just to conclude, I mean, I've given like a really quick sort of snapshot of some of the work that's been happening in polio eradication. And certainly what's clear to me since I've been working in this area for quite some time now is that commitment at all levels for polio eradication is really critical. And this is present in Nigeria, and consequently the ability to innovate and use modern methods has thrived. But unfortunately the situation is just much more complicated in Pakistan, and their polio is thriving. There are many tools in place to optimise eradication. So, you know, we're ready with some of the immunisation planning. We've got this up-to-date, really real-time surveillance network. And we've also got mathematical and statistical models available to help inform what policy should be going into the future. And the final thing to say is that with no more cases, we've achieved elimination, but eradication can only happen when you start to withdraw the vaccines. And that's an entirely other different ballgame, and something that I think would be quite exciting to look at. So just the final thing is to thank everyone that I work with, and the funders, especially the Medical Research Council that funds my fellowship. Thank you for listening.
Questions, please. Thanks. Is there any modelling done where there's civil wars? So I'm thinking Syria and IS. Do you expect there to be no outbreaks, some outbreaks? I mean, what is the experience of civil war and polio?
So, a reasonable amount of experience. I think a lot of it is the expertise in the partners, so especially WHO, UNICEF, CDC. They are really great in working in places such as Syria. So when polio arrived in Syria, I think in 2012, once they realised how serious the situation was going to be, there was a huge surge in resources being based in Syria to carry out vaccination plans. And I think the result was, well, very low number of cases. So although there were issues, and obviously that came up in the medical press, I was very impressed by the scale at which they were able to move resources in the right direction. Another piece of work that I'm doing, again in collaboration with WHO, CDC, the Institute of Disease Modelling in Seattle, and UNICEF, is to, so we're all part of this thing called the RAT, which is the Risk Assessment Task Team. And one of the things that we do is that we develop statistical and mathematical models to help inform immunisation campaigns looking forward into the future. So this was work that sort of initially started in about 2011, but one of the really critical things, as you rightly point out, is civil unrest. So the model that I've developed with WHO explicitly accounts for that as a risk factor, because it does show up. Another really important thing is the movement of refugee populations, both internationally but also nationally. So what was very apparent in Syria was the high number of IDPs. So I think 40% of the population were either refugees or IDPs. So that put Syria at huge risk in terms of exporting the virus, but also receiving the virus once again and not being able to cope with it. So there's a lots of work happening in the background that is shared between partners that helps exactly answer that question.
One more question and then we'll move on to our final talk.
Thank you for the talk. It was excellent. I come from Indonesia, where sadly there is a growing resistance to vaccines. There are a lot of conspiracy theories around, and there are movements that will jump at every opportunity to pressure people from to not vaccinate their children. So I wonder, how did you explain the risk of this vaccine drive on poliovirus without putting off people
So accounting for that.
vaccinating their kids?
Yeah. So in Nigeria, certainly in 2008, there was quite a large epidemic of vaccine-derived poliovirus. So part of that, those large peaks in the epidemics, and a lot of that was around beliefs about the oral polio vaccine having negative outcomes, and there was an increase in refusal in some states. Vaccine campaigns were not allowed for exactly that reason. It's a very complicated thing to understand why people choose not to be vaccinated, and a lot of it is passive, in terms of, well, my children they're just not available, or not outwardly seeking help. And it really varies from, not just from country to country, but from village to village. Some of the work that is carried out when they do the post-campaign monitoring activities, they're looking for finger-marked children, but when they see children that haven't been finger-marked, there's a very loose interview. I think a lot of people would agree that the interview could be a bit more rigorous in terms of understanding, well, why was that? Did someone visit? If they visited, did you open the door? If you opened the door, did you have a conversation about immunisation and what this is? And it's about trying to understand the causes for refusal, but also in terms of communication, and to better understand, what is it that's missing. It's very rarely a true misunderstanding. Well, it's very rarely a true refusal. It's more a misunderstanding of, well, potentially the benefits, but also sometimes it's used to leverage other healthcare as well. And I think it's understandable. If you're worried about measles and your child's getting immunised against polio, it doesn't always make sense. But a lot of work is being done. So there's another website called polioinfo.org, which looks at exactly those questions and really helps to focus in specific areas, like regional areas, what to do about vaccine refusal.